everyone. Welcome to our first segment of Clinical Pearls. I hope this will be the first one in several that we do for your modules, and I hope to have a guest speaker each time, and we're going to just hit the highlights of whatever module is due that week. So today I have with me our first guest speaker. This is Dr. Jared White. He is board certified in general surgery, but also did a transplant fellowship where he transplanted pancreas, liver, kidneys, and now is a UAB attending physician where he primarily does liver transplant and hepatobiliary surgery. So definitely an expert in the world of the abdomen, which is our topic for this week. Thanks for joining me today, Dr. White.
Thanks for having me.
We're going to just start with the basics. So you are the physician, or in our case, the nurse practitioner, and have been asked to see a patient, say in an inpatient setting, the ED, or perhaps even on the floor in the unit. All you know about this patient is that they have severe abdominal pain. Don't really know any history. So where do we even start?
Well, my approach for abdominal pain, initially I want to know, is this someone who is going to need an operation or may possibly need an operation versus someone that can be observed. And so, nowadays, typically if I'm presented with a patient that I'm getting consulted on, they've already had a CT scan or they've already had some diagnostic workup, which kind of gives you the impetus to try to not actually see or talk to the patient and just treat an x-ray. But I think there's a lot of information you can gain from doing a full history and physical exam. And for example, a lot of the things that the patients may tell me might lead me either for or against performing an operation. So I think it's key for the initial evaluation to just get a basic history, and that can be, anything from, details leading up to their pain, if they're in the emergency department or if they're in the inpatient setting. I want to review kind of what's been done, what all got them to the point to where they consulted me. And then the things I like to know is kind of what are the factors associated with their pain? Is this an acute onset that followed some particular event, such as eating, or certainly ensure they haven't had some type of trauma or something that might point me in that direction? Are they heavy drinkers, which might lead me down the road of pancreatitis? Do they take particular medications such as goody powders and anti-inflammatories that might lead me down the road of a perforation or a bleeding ulcer? Obviously, trying to distinguish, is this something that needs an acute operation now, or is this something that might eventually become an operation, such as diverticulitis, where they may have acute onset of pain, but they certainly don't necessarily need to go to the operating room right now, and may actually be improved with just antibiotics alone. So again, taking a initial history from the patient and letting them tell their story will a lot of times, maybe 90% of the times, point me in the direction I need to go. After my initial history, I obviously want to perform my physical exam. My exam for the abdomen is going to be focused predominantly on the abdomen, but then anything thereafter that I find pertinent, such as if I'm worried about a malignancy, I'm going to look for lymph node basins. When I perform their physical exam, I'm going to be looking for scars, prior evidence of surgery, or something that might lead me to be concerned about adhesions, bowel obstructions. Have they had hernia repairs, things like that. And then, based on where their location of pain is, and I'll typically ask the patient to just, point where's the pain? Is it diffuse? Is it localized to one side or the other? And I typically will try to leave that place for last. If that's where they're hurting, I will examine the abdomen and all the other quadrants and come to that. I think the important thing in distinguishing if someone needs an operation right now versus someone we need to observe is, do they have active peritoneal signs? And I think probably the easiest way of determining that is just visually look at the patient, see how uncomfortable they are. Folks with peritonitis, they're actually very still in the bed. They don't want to move because every time they move, or they may tell you, when I was on the ride over here, every bump we hit in the road was just excruciating. So that points towards peritonitis for whatever the source, whether it's diverticulitis, perforated, viscous, appendicitis, and so forth. So that's very important. And by looking for peritoneal irritation, either rebound tenderness, severe rigid abdomen. These patients, whether they're flexing or not, their abdomens will a lot of times be rigid, and so that ups your concern for for peritonitis or someone that may need surgery. Once I've done my thorough physical exam, if by that time I don't have an idea of what I'm looking for, if I haven't decided, yes, this is appendicitis, or maybe this is a bowel obstruction or cholecystitis, what have you, then I would proceed on with getting my diagnostic laboratory and perhaps x-rays focused on my differential, which may be extensive, but that's what I'm going to tailor my labs. If I'm concerned for pancreatitis, I'm going to check amylase and lipase. If I'm concerned for appendicitis, I want to make sure I've got a white count. Most all of your patients, you're going to get a fluid balance panel, a CBC, and perhaps LFTs if felt indicated, and kind of tailor your laboratory exam from there. And then imaging. Not every patient needs to be imaged. If I think I have appendicitis, I don't have to have a CT scan to take that out. And certainly nowadays, since we have good CT scans, they're very quick. Running them through the scanner is quick and easy, and sometimes can avoid an unnecessary operation. But you have to determine what kind of imaging is going to get me the best information, and am I going to use contrast? Do I need oral contrast or IV contrast? Maybe all that I need is an actual ultrasound and save them the radiation. So those are kind of the initial things that are going through my mind, and certainly any medical students, nurse practitioners, physician extenders, they don't have to approach the patient as a surgeon. They want to approach the patient as, how can we get the best information to determine, is this someone who needs an operation right now? Is this someone who may need an operation over the next few days, or is this someone that's most likely going to be treated conservatively?
All right, thanks. So let's go over just a couple kind of specific differential diagnoses. You've gone over a general overview of the patient and sort of your clinical approach, but I've got some specific things. So these are differentials that may be going through your head or should be going through everyone's head as they're examining their patient. And I would like for you to just kind of tell me the quick and dirty, if you will, what you would look for or expect to see in these patients, and how you can differentiate one diagnosis from another.
Sure.
So let's start with acute appendicitis. What kind of tests are you going to be doing for that patient, and what do you expect to see?
So with appendicitis, this is one of those classic presentations of an acute abdomen where if you listen to the patient and give them a minute or two, they're going to lead you down that road very quickly. Most of the times, patients, they may have woken up feeling fine, and then throughout the day, either with eating or just in general, they feel just not quite themselves. They feel kind of puny. They typically will get nausea. They'll tell you they'll have nausea. And a lot of them will actually throw up or have just a change in bowel habits, such as an episode of diarrhea preceded by then vague abdominal pain that starts out around the umbilicus, which is typically what we call referred pain, because this is visceral nerves that are being affected. Now, as that appendicitis and that inflammation progresses, and you get a phlegmon or you get inflammation around that obstructed appendix, then you actually get peritoneal irritation. So that may take place over half a day to 24 hours. So their pain, they'll classically describe, started out around my umbilicus and then shifted down to my lower right quadrant. Very classic for appendicitis. Now, there's certainly things that can present very similarly, things that to also consider. Is this a young female who might have ovarian torsion or a ruptured ovarian cyst? So those things, we'll keep in the differential. But again, on my physical exam, if I'm concerned for appendicitis, you've got, of course, McBurney's point tenderness, which is pretty classic for the area of peritonitis. You've got the psoas sign and the obturator sign, which aren't quite as specific, but you certainly can see them with flexion of the hips, internal rotation. These patients don't want you to do a whole lot to them because they hurt from peritonitis. And, you can mash on them all you want. One trick I used to do is just, walk into the room and kind of bump their bed, and you'll see their face grimace. It's a way to test for peritoneal irritation, same as rebound. When you let off, that shaking is what bothers them. And so that's pretty sensitive. Now again, if I'm not, based on their exam, based on their blood work, I typically will look for a mildly elevated white count, 10, 14. It's usually not, if it's 25 or 30, I'm thinking there's something else. This doesn't sound like appendicitis. It may be a ruptured appendicitis with a abscess or phlegmon, but they'll typically only have a vague white count. They may have fever associated, and then there may be some other vague symptoms. If I have any concern that I'm not just quite ready based on their story and their exam to take them to the operating room, I would always, consider checking a CT scan at that point.
Okay. So just a note for you guys, those tests that he mentioned, make sure that you know how to do each one of those. If that takes looking it up or if you remember from other courses, that's great. So what about diverticulitis?
So diverticulitis is, can be a spectrum, and a lot of times we'll see diverticulitis that may just be presentation in clinic where, someone has, and most commonly down in the lower left quadrant where the sigmoid colon is, which is the most common location of diverticulitis. They may just have mild inflammation and something that, they're not septic, they're not critically ill, they have some pains, maybe it's relieved with bowel movement, or maybe they had some diarrhea. Occasionally they'll pass some blood in their stool, probably the most common cause of bloody diarrhea. Now those patients, typically you cool them off with antibiotics, they may get better. The other end of that spectrum is someone who has a very severe diverticulitis. They may have perforated, they may have intra-abdominal abscess associated with sepsis. Now that's the patient I'm seeing in the ER who's tachycardic, hypotensive, basically an acute abdomen. And there's different studies suggesting that these patients can be managed differently than when we would do in the past, which was take them to the operating room, put them through a big operation and cut out a portion of their colon, leaving them with a Hartmann's pouch and an ostomy. Nowadays, some patients who are not septic, who are not at risk of perhaps dying from their acute sepsis, you can take them, do a washout, or do even a laparoscopic washout of their abscess and try to get source control, and then try to bring them back later for a colon resection, obviously covering them with antibiotics. But those patients are typically going to present with pain. It can have pain diffusely, depending on how much peritonitis they have. They can have diverticulitis on the left or the right side, so it's a little less sensitive that you can determine that that's definitely what it is. Obviously, they'll have an elevated white count if it's a severe case. Typically, you're going to see that on a CT scan for sure.
And acute cholecystitis. And can you differentiate if there is a difference between that and cholelithiasis?
Yeah, so dear to my heart, involving the liver and the gallbladder. Cholecystitis, similar to appendicitis, kind of follows a pretty classic presentation. A lot of these patients will have what's truly known as biliary colic, which is not the same as cholecystitis. Biliary colic will come on with fatty meals and specific, fried foods. You ask them about creamy, dairy, fried foods, and they'll tell you, oh yeah, I get pain, right upper quadrant, intense, stabbing, severe pain, and it lasts about an hour and goes away. So that's biliary colic, not truly, or cholelithiasis, if you will, not truly cholecystitis. When we worry is when they tell me, yes, this came on, started yesterday, I've had fever since, it's continuous, it's unrelenting, I'm throwing up, and those patients can be acutely ill and truly have an acute abdomen. Well, typically, pretty classically, you'll see that on physical exam. Pain localized to the right upper quadrant. Occasionally, they get referred pain to the shoulders, but the Murphy sign is one of the more common signs that you'll see in here, and it truly is pretty sensitive. When we get an ultrasound, this is one of these that you don't really need a CT scan. An ultrasound is actually more sensitive and specific for cholecystitis, but they'll actually visualize the gallbladder and push down, and the patient will gasp. It's when they're trying, you ask them to take a breath, and on inspiration, they'll stop breathing because it hurts so bad against that inflamed gallbladder. And that's Murphy's sign, and pretty classic. And as far as my management, I'm either going to cool them off with antibiotics. If they're, if I've deemed them a good surgical candidate, we can take their gallbladder out, laparoscopically or open. very sick patients, pregnant patients, elderly cirrhotic patients, it may be best just to place a cholecystostomy tube and cool them off and temporize them in the meantime.
Here's a good one: acute pancreatitis.
So, acute pancreatitis is one of those that I have high suspicion of just by the initial conversation I have, or the family may be the one telling me. A lot of these patients with pancreatitis can be super sick. I mean, they may present to me already intubated and septic, and already had a code event. But ultimately, patients with high alcohol use, history of high alcohol use, or drug use, or there's certain medications you have to be suspicious of, steroids and hydrochlorothiazides. There's of course a lot of classic things that are much more rare that present with pancreatitis. But typically these patients are going to have, it's a retroperitoneal organ, so they don't necessarily present with an acute abdomen. They present with a lot of times epigastric pain or pain in the upper quadrants. But in severe cases, such as hemorrhagic pancreatitis, you can actually see overlying skin changes known as the Cullen and Gray-Turner syndrome. And this, when you see this is retroperitoneal bleeding that's necessitating to the skin. They always say Turner or the Gray-Turner sign is, you think of them as turnover, so it's flank retroperitoneal hematoma, whereas the Cullen sign is periumbilical. But it's just basically retroperitoneal blood that is tracked in the skin layers or the soft tissue layers. These patients typically are going to make them MPO, or at least get access for enteral nutrition. They may need tons of IV fluids, they third space, and it can be quite ill. Not really a surgical indication. This is one of those acute abdomens that the last thing I want to do is go operate on them. I'm going to make them sicker.
Right.
I'm going to support them through it. Now they may develop complications such as pseudocysts, pancreatic necrosis, or abscesses that may require surgery. But overall, acute pancreatitis and even chronic pancreatitis are, for the most part, non-operative disease. So,
What might you find with the GI bleed? And you mentioned already the Gray-Turner sign, which I had listed under there, but any other symptoms or signs that a patient might present with?
Sure. So with GI bleeding, of course, this may actually be painless. They can hemorrhage and bleed from any source from the mouth to the anus, and pain may not be their presenting symptom. Maybe hematemesis or melena or hematochezia is what they're going to present with. And then it's important to know their history. Are these patients that are coronary artery disease in their own Plavix and aspirin and Coumadin, or they've had a DVT? So I want to know what their medications are. Are they on blood thinners? The other thing which I typically see are cirrhotic patients with esophageal varices, which probably 70% or more of the GI bleeding cases that we see, or at least severe, are related to portal hypertension and esophageal varices. So frequently these patients don't present with pain, but they can present with very catastrophic bleeding. Kind of a change historically is that, in the past, 100 years ago, any GI bleed was a surgical emergency, and we did a lot of big operations, taking out the whole colon, taking out part of the stomach, things like that, and maybe not even finding the bleed. So obviously the initial management of a GI bleed is really non-operative. It's localizing the site of bleeding. Doesn't do any good to go in and take out somebody's colon to find out they're bleeding, from their anus or from their stomach. So, endoscopy is playing probably one of the most major roles nowadays, and that we can, stop GI bleeds, upper GI bleeds with varices with endoscopic banding. You also have angio and embolization and TIPS procedures for our cirrhotic patients. For patients who are having lower GI bleeding, of course, surgery plays a role, but we'll still a lot of times try to localize either diverticular bleeds, angiodysplasias, AVMs, all of those type things, colon cancers. I want to try to either get an angiogram, CT colonography, or even a tagged red blood cell scan, or a nuclear medicine scan to localize the site of bleeding. You're going to cut down their morbidity and mortality with a focused operation rather than taking out a whole colon, for example.
And we talked a little bit about it when we were prepping for this. Bowel obstruction, that can present in some various ways, correct?
Certainly. So, bowel obstructions, it's important to take a good history with bowel obstruction, or at least a surgical history, because, rarely do patients, unless they have a hernia that they've known about, it's pretty rare to have a bowel obstruction without some prior surgery. So hernias and adhesions from prior surgeries are the two most common reasons to have a bowel obstruction. So I have to be a little suspicious if somebody's got a bowel obstruction and they don't have either a hernia or a prior surgery. And that puts me into a whole new category where I'm worried about malignancy. Now, obviously, a 20-year-old presenting with a bowel obstruction, I think malignancy is low on the list, but you always have to have that in mind. So some colon cancer that wasn't known about, or some vague, Meckel's diverticulum, something that is a lead point for the bowel obstruction. Now, these patients will typically present with diffuse, kind of crampy abdominal pain, typically not going to be localizable, but they'll often be distended. They may be throwing up, but their abdomens are very tympanic, so on percussion, they sound like a drum. They may tell you, yeah, I haven't had a bowel movement or passed gas in 2, 3, 4 days, a week, so, you worry about if, based on the age range, if they're 90 years old, they're in the nursing home, those patients are chronically constipated, you worry about colonic torsion, sigmoid torsion, or any portion of the colon contorts, and that can cause and present as a bowel obstruction. These typically aren't peritonitis unless they've perforated. They don't present with peritonitis, so you can shake their bed, you can do rebound. They just kind of have dull, crampy. A lot of times they'll tell you it's intermittent. They feel their bowels squeezing, and then it'll release, and they'll get some relief, and then it'll come on again. So so bowel obstructions are going to present a little bit differently than, say, a perforated organ.
Are these always surgical candidates, or can you treat them conservatively?
So, initially, the old teaching was you never let never let the sun rise or set on a bowel obstruction. So, back in the day, before my time, they would operate on these, as soon as you see them. Now, we typically will at least give them a chance at observation. Go ahead and decompress them. Get an NG tube in. Give their bowels a chance to sort themselves out. Now, you got to watch the patient. Obviously, if they present septic, peritoneal signs, not getting better, you're checking KUBs, they're still not improving, or my impetus to operate kind of is dictated by how severe the obstruction looks. If they've got an obvious transition point, no contrast going by on either a CT scan or on upper GI series, then there's not a whole lot of reason to wait. You can wait for as long as 3, 4, 5 days to a week. On these patients, if they haven't opened up after 3 or 4 days, the likelihood of them opening up is pretty low. But again, the situation is driven by how many surgeries they've had. Or am I going to go in and be able to fix their problem? If I suspect that they've had multiple operations, maybe they had perforated in the past, maybe they had cancer, then going in and operating, we could actually create a bigger problem for them, making enterotomies and those kind of things. So then you might drag your feet even longer, maybe even try TPN for those patients that aren't going to tolerate an operation as well. But for the good surgical patient, someone who's not opening up or has a severe bowel obstruction, it's always safe. You'd rather go to the OR and have an operation go straight forward, or perhaps not need it, than to sit and wait and have them perforate and have complications. So.
Okay. And just a couple more. One, I think this one is pretty rare, at least from my background. Mesenteric ischemia. It's very, very, very serious.
Yeah, and it's one that you won't forget it when you see it. And fortunately, I've only seen it a few times, but these are your vascular patients. Sometimes patients who, it's a classic board question for general surgeons, but patients who have had an angiogram, a cardiac angiogram, for example, and then in the PACU they started having severe abdominal pain. That's we worry that that's very classic for mesenteric ischemia, and what this is just decreased or absent blood flow to the bowels, typically through the SMA, superior mesenteric artery. So post-procedure, if you've had an angiogram, then you worry about plaque, from the calcified aorta, for example, flicking off. Vascular patients, smokers, diabetics, hypertensive, hyperlipidemia, these patients have If you scan them, look at the non-con scan, their vascular tree will be filled with calcium. They may have a completely calcified ostium of the SMA, so it just takes a little bit of plaque or a little bit of thrombus, and they can thrombose their whole blood supply to their bowel. So these patients, the classic teaching is they're going to present with pain out of proportion to exam. So they are absolutely, it's you never forget that when you see that patient whose abdomen, they're soft. There is nothing that overly particular, but the pain that they're describing is worst pain in their life. And so when you hear that this is the worst pain I've ever had in my life, you have to be concerned about mesenteric ischemia. And those patients, immediately, if you can get a contrasted study on to determine if they've blocked out their flow, where it's blocked, initially they're going to buy themselves an operation, but if you can get them on heparin, get them anticoagulated, you may preserve flow to the bowel. These are patients that, get very, very sick. You take them to the operating room, you may be resecting gangrenous bowel or bowel that's ischemic, and a lot of times we'll leave these patients' abdomens open. We'll temporarily close them because we got to preserve enough bowel, and you don't want to just resect everything. So we'll bring them back, try to resuscitate them, keep them on, heparin, and see if you can optimize their blood flow best you can. Bring them back the next day for a second look, and if there's more unviable bowel, you got to resect it. If not, if they're off pressors and they look good, you can try to hook them back up and get them through to fight another day. So, but mesenteric ischemia can be a dramatic disease for sure.
I think the last one we'll go over today is the AAA, another really scary one if it's a ruptured AAA, obviously.
Yeah, ruptured AAAs, a lot of times you don't have a whole lot of time. This is rarely do patients not know they've had a AAA. A lot of patients know they have them or they've been followed and they rupture. The patient that didn't know they had one and ruptures and there's any delay in their care, that's, can be invariably fatal. Now, typically AAAs don't necessarily cause pain unless they have, if you have an inflammatory or mycotic aneurysm, they can present solely with either malaise, weight loss, not feeling right, some inflammatory process, but they can have acute pain too, just from the inflammation of the aneurysm. These patients, if they have a significant aneurysm, you can actually palpate through, deep palpation of their abdominal exam. And if you haven't felt one of these, when you do finally feel one, it kind of takes you back because they're pretty large, pretty bounding masses. The best management of these is obviously going to be in the hands of a vascular surgeon. If you have somebody that's ruptured and has a contained rupture, it's much less open general surgery or vascular surgery now, and a lot more endoscopic or endovascular repair with stent grafts that can occlude these hemorrhages or these aneurysms from completely hemorrhaging. So the management of these AAAs has changed over even the past 10 to 20 years. But again, these can be very asymptomatic. It's something that the physicians on the front end, the family practice docs, and have to have a clinical suspicion and doing good exams to pick up these aneurysms and have them followed by the appropriate vascular surgeons. So.
Great, thank you so much. Any parting words to our upcoming nurse practitioners about abdominal exams or anything like that?
Well, I think just getting comfortable with performing the exam. You can't get this stuff out of books. You really got to, your patients are your best book. So trying to, every patient you see, practice your physical exam on them. My physical exam gets better each time I do it because I'm learning and I'm picking up and learning little tricks as I go. So there's, certainly a lot to learn to try to get comfortable with all these differential diagnoses. And then as you're seeing these patients, you're listening to their stories, you're examining them, you're putting all the information together. You're trying to basically chip away at each of those in your differential to and you don't always have to have it right. As long as you are on the right track, you can really help these people. And go Vols.
Oh. Thank you, Dr. White.